Okay, so welcome to the final session for today. I'd to introduce myself. I'm Brendan Delaney. I'm Chair in Medical Informatics and Decision Making at the Institute of Global Health Innovation at Imperial College. I'm also a GP partner 1 day a week in South East London. And Nikki, if you'd like to introduce yourself, my co-chair.
Yes, hello everyone. So I'm Nikki Smith. I'm one of the founding members of our charity Long COVID Support. I'm well into my 4th year of long COVID, so apologies if I go a bit croaky today, but a few symptoms have flared up. And so back over to you, Brendan.
Okay, I'm not surprised, Nikki. We'll stalwart there. So I'd like, great pleasure to introduce our first speaker, Prof Ami Banerjee, who's Professor of Clinical Data Science at UCL and an honorary consultant cardiologist, and one of the big lights of the long COVID research world in the UK, being co-chief investigator of the Stimulate ICP trial. Ami, over to you.
Brendan, thanks very much, and thank you, Nikki. So I'm Professor of Clinical Data Science at University College London. I'm a consultant cardiologist, and I've been given this this slot to talk about what we've learnt from long COVID research. These are my disclosures. I work clinically 30% of the time. I am not a dedicated long COVID clinician. My colleague Melissa Heitman runs the University College London long COVID clinic with many other colleagues like Toby Hillman and Emma Wall, and I see some of the cardiac complications of long COVID, but I have been doing a lot of long COVID research. These are my funders, and I'm a trustee of the Long COVID SOS. So I'm often asked how I got tangled up in this space, and it's because of this really. The first report from Wuhan in January 2020 showed in the Lancet that of the people who were admitted and dying from COVID, a good proportion had underlying chronic diseases, particularly diabetes, hypertension, cardiovascular disease. And we went on and did some work about underlying risk in actually leading to COVID mortality, to predict excess deaths. So the so-called direct effects of COVID, which informed the decision to lock down. But over the following year, working with many different colleagues, this was with colleagues from the Office for National Statistics, we looked at that stage pre-vaccination, over 40,000 people in hospitals with COVID, and looked to find that in about 4 months there was a high mortality rate of 12%, and 30% of people were readmitted, and there was new chronic disease, diabetes, cardiovascular disease, chronic kidney disease, chronic liver disease. So that was in hospitalised people, but also in the University College London long COVID clinic, we were already finding with a year and a half of their clinical experience that people who are non-hospitalised were no less impaired. Here you're seeing the proportion of people who in the non-hospitalised population at UCLH clinic were off work or unable to work full time. We were also interested in organ impairment. So other than the brain, in the first wave, we scanned people post-COVID and looking across all the major organs using the cover scan led by colleagues at Perspectum. And we found that, first of all, there's a range of symptoms, and we looked at 1 year of follow-up. And I guess the good news is that the symptoms were less common in people at follow-up, but there were still a lot of people who are still getting symptoms at 1 year. But on the bottom here, you're looking across different MRI metrics in the different organs. And without getting into details, there were some people with mild abnormalities across all organs, from heart to pancreas to lung to kidneys. And to put some numbers to that, we looked at our cohort of 530 or so people, and 60% of people had organ impairment at 6 months, and a good proportion had persistence of organ impairment at 12 months in one organ. And in my home territory of the heart, everybody's what was very interested in myocarditis and inflammation of the heart at that stage, but actually other forms of cardiac impairment, such as a reduction in the pumping function of the heart, was present in 1 in 5 individuals with long COVID at 6 months, and half of those, so a quarter overall, had an abnormality at 12 months. So I'm reminded of this quote by Desmond Tutu: there comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in. And in chronic diseases, including in heart failure, where I'm a specialist, and in many other chronic conditions, this prevention spectrum is helpful, where in terms of long COVID, we know that the trigger is SARS-CoV-2 infection. So although it's really been taken off the menu, still avoiding COVID infection or SARS-CoV-2 infection is the best way to avoid long COVID. And we know from various studies that reinfection increases the risk of long COVID. And getting vaccinated also reduces the risk of long COVID. But the rest of our care has been to try and recognise and refer people with long COVID as early as we can, and rule out other treatable risk factors in disease, and then to signal people towards rehabilitation, symptomatic treatment, and research where possible for new treatments. Just in the last week or 10 days, these are some headlines that are highly pertinent. The British Heart Foundation conducted a study showing 100,000 excess cardiovascular deaths in the last 2-3 years during the pandemic. So these are not necessarily linked with long COVID. They might be. It's very likely that most of them are due to indirect effects of the pandemic on the strain on the NHS. You might have already heard from other speakers about the British Medical Association's report this week that 1 in 5 doctors have been so functionally impaired by the effects of COVID and long COVID that they're unable to work to their ability. So this is a huge effect in our health workforce, and probably in every workforce. And the journal Nature had this focus last week on long COVID recovery. So this is just to highlight that we do need, people rightly are wanting treatment studies, but we also need over time to do the epidemiology, to do the follow-up in different centres in different countries to find out what the recovery rates are like, particularly in the post-vaccination and with antivirals era. And what we see is, in one study of 1,000 people, about a quarter of people still had symptoms at 6 months, dropping to 19% at 1 year, 17% at 2. So there are some people who carry on having symptoms of long COVID up to 2 years from some of our larger cohort studies, but most people do get better. And we haven't got any proven drugs in phase 3 or phase 4 for long COVID yet, but we have started to get signals from, metformin, which is an anti-diabetic drug, and an antiviral drug, Paxlovid. So that tells us not only about the drugs, but it tells us about the potential mechanism of long COVID being something to do with the cardiometabolic axis, and also the persistence of the virus. It might be important, but these two only have been shown to be effective in the acute phase, not in people with established long COVID. So I always show this model of the learning health system to show how cardiovascular disease or other chronic diseases overlap with long COVID, and often multimorbidity occurs. So people have other chronic conditions, be it asthma or diabetes. So I've mentioned direct effects of COVID, indirect effects, and long COVID I call a long-term post-COVID effect. But other chronic diseases can be a risk factor for those, can be caused by long COVID as well as an outcome. So we shouldn't think of long COVID in isolation. We must think of it in the health system context and with other diseases. That's what we tried to do in the Stimulate ICP study. I co-lead with Melissa Heitman, who's a consultant physician at the long COVID clinic at UCLH and the national lead in this area, and a team across many universities, hospitals, and other partners. The next speaker, Nisreen Alwan, is going to talk about inequalities and is a key player in our team. So there's 3 parts to our program. One is looking at the current services for long COVID and what we can learn from the burden of disease and care that's going on. The second part is a complex trial where we have been looking at an integrated care pathway of doing that cover scan, the multi-organ MRI scan, comparing that with usual care, and also comparing a digital rehabilitation platform with usual rehabilitation care. And also we have a drug platform study, which currently has, sorry that this slide only has the antihistamines, loratadine and famotidine, there were delays in getting started to get the other drugs added, but there was rivaroxaban and colchicine. So antihistamines, blood thinners, and anti-inflammatories are being tested here. And there's also a third part of the program, which is looking at inequalities, which I'm sure Nisreen will touch on. In the trial, there have been various regulatory delays, but also when I say that we have to think of long COVID in the current context of the strain on the NHS and research infrastructure over the last 3 years, the change in focus from acute COVID, the long-term complications, i.e. long COVID, have not been prioritised and taken as seriously. And as a result, we've recruited just over 800 people to date, 270 of whom are in drug arms of the study. We have now had an amendment accepted to accept sites which are drug only. There's a big delay in getting that amendment approved, and we're also seeking approval to accept people who've had long-standing long COVID, because initially we were looking at our pathway overall. And importantly, I'll touch on this in a couple of slides, liver and pancreas impairment in our preliminary analysis seem to be important with the cover scan. In terms of the current care, we know even if we focus on the 6 clinics where we're focusing our study, that's Hull, Leicester, Derby, Exeter, Liverpool and London, that there's huge variation, huge strains on the services, different clinic designs, different patient flows, so potential for inequalities there. And we're getting better data nationally on this now. From our programme of work, there's been evidence of clotting abnormalities, which have been shown in a subset of people with long COVID, which may inform the tests that we do and support the use of rivaroxaban, the anticoagulant that we're trialling at the moment. On the left of this slide, so this is big data analysis from a national trusted research environment. These are preliminary results. On the left, you see people with COVID, about 18 million people post-COVID, and on the right, nearly 300,000 people with long COVID. And what I want to draw your attention to is that the red lines, so for each of those groups, we've got mortality and hospitalization. The red lines are people with cardiovascular disease. And so people with cardiovascular disease, or the blue lines, are people with higher cardiovascular disease, but not cardiovascular disease, such as diabetes, such as hypertension. These two groups have higher mortality with both COVID and long COVID. Even in long COVID, which has a low mortality, if you add in cardiovascular disease on the right of this slide, then it has a mortality of about 15% at 2 years. And the hospitalization is sizable. And again, risk factors are important. So in the context of COVID and long COVID, we still need to treat other chronic diseases. This is, sorry, this is a bit more complicated, but this is showing that if you compare vaccinated versus unvaccinated cohorts across all outcomes, mortality and hospitalization is lower post-COVID and post-long COVID, whether you look at cardiovascular disease and whether you look at people with high cardiovascular risk. So we still support vaccination in people with COVID and long COVID. In terms of healthcare use, if anybody's in doubt about the burden of disease here, we've been looking at the cost, comparing with control populations. So on the left-hand column here, we've got people with long COVID. We've got comparison with people, with those same people before the pandemic and their healthcare utilization. We've got people without COVID pre-pandemic, and we've got people who didn't get long COVID but did have COVID, and a contemporary non-COVID population. Other than the people with COVID and no long COVID, everybody else has lower healthcare utilization, from GP through to A&E through to hospital admissions. Long COVID is a burden on the health system, burden on those individuals, which is more. And the only reason COVID without long COVID is more is because there's in the first two waves there was such high hospitalization and critical care costs. Sorry, final couple of slides. This is the liver and pancreas. I've skipped over there, but that supports the use of the metformin data, and we should look at that axis as well as the antivirals. So this is a common condition. It's costly to individuals and health systems. It's connected to other chronic diseases and other healthcare utilization. We've got to do better at coupling the bench science to bedside to big data, and we've got to keep funding the research, not least the studies that were started in the first wave, so that we keep the insights. And I think there's a great opportunity in the middle of this difficulty. Thank you.
Okay, just before our next speaker, I just want to say a big thank you to our sponsor, Eureka Health. Eureka is an online community where people with chronic disease can discover new treatments, connect to others with similar health profiles, which we know has been critical with long COVID, and share what's working for them. So please do check them out at eurekahealth.com. So next, we'd like to welcome Professor Nisreen Alwan. Nisreen is a Professor of Public Health at the University of Southampton and Honorary Consultant in Public Health at University Hospital Southampton NHS Foundation Trust. She leads research in maternal and child health towards optimising the well-being of families, preventing future chronic disease, and reducing health inequalities. During the pandemic, she focused on the quantification and recognition of long COVID and is now conducting research on long COVID health inequalities. She was awarded an MBE for services to medicine and public health during the pandemic in the Queen's New Year's Honours 2021 and was named in the BBC 100 Women 2020 list among women leading change from across the world for her long COVID work. So welcome to you, Nisreen.
So thank you for the introduction, Nikki. I started by, okay, they're not moving. Okay. I saw Ami had the disclosure bit and I thought I'll just put the slide to disclose that where I'm coming from in long COVID, but you did mention it in the introduction. I came into long COVID really as somebody who's struggled with it from my infection in March 2020 with COVID. I put this is the first kind of, if you like, article in a medical journal that I wrote about it. And I came at it from a patient perspective, but also from a public health, doctor's perspective, in terms of, the quantification and the kind of quantifying the problem of long COVID, which wasn't happening at all back in 2020. Well, now we had the UK Office for National Statistics quantifying long COVID. We had some regular data and this is the latest one. The latest release, unfortunately, was back in March 2023. So you can see that I think some other speakers have kind of highlighted how big the problem is in terms of the number of people struggling, number of people who have limited day-to-day activity because of long COVID. I'd like to just drill down into a bit more into this ONS data just to show you some characteristics. So not everybody is getting long COVID equally, and this is not surprising. This is something we have over and over again in public health and population health characteristics. So you can see obviously variation by age group. So the middle sort of 35 to 69 age group with the highest prevalence. This is long COVID for more than for a year or more, that for a duration of a year or more, this is the prevalence. We can see in females is more prevalent than males, but not a huge difference as is maybe kind of reflected in some of the media, but also in some of the research study recruitment. Also, we can see by deprivation, so IMD index of multiple of deprivation, those who live in the most deprived area, in the quintile of most deprived area, almost twice as more prevalence than the least deprived. So a huge gradient by deprivation, and also a huge gradient by if you have a health disability or status pre-COVID. You can see the prevalence is much higher with people who have pre-existing health conditions. We can also see this variation in terms of the occupation. So this may have to do obviously with exposure to COVID, some frontline professionals, but also maybe to do with how you develop long COVID, how much rest you can get, after getting the infection, sick leave, the flexibility and the type of physical and mental stresses of the job. So you can see we've got the highest in social care, but also high prevalence in teaching, education, healthcare, and transport. So all of these different characteristics, I'd always like to show this because I think this is a good framework in terms of the wheel of power of privilege. We don't live in single identity kind of dimensions. All of us have characteristics in all these segments in this wheel of power. And when they combine, they shape our experiences. So if we relate this wheel of power to long COVID, you can see the combination of these characteristics, or how far you are from power, can shape, whether you get COVID or how likely you are to get COVID, how likely you are to get long COVID, how you cope and deal with living with long COVID, and the adjustments you can make to your life, and how you approach care and support, and obviously what can you do to recover from long COVID. So health inequalities, we know, affect long COVID as they do in almost every other chronic condition. And it's a vicious cycle. There's testimonial injustice. If you are in that wheel of power, with characteristics maybe away from kind of the center of power, you would struggle with that. People are more likely to be dismissed. Their concerns are sometimes dismissed by the service providers. And this is obviously made worse by pre-existing structural inequities. Then what happens? People start internalizing the stigma, so start kind of feeling, is there something wrong? Being ashamed of their illness, but also could be anticipating. So really avoiding seeking support and care because they don't want to be in that position where they're being judged and dismissed. So we did some research with colleagues from Long COVID Support, co-producing this research, looking at long COVID stigma. We in the UK context, the survey did include wider than the UK, but within the UK population, we found these findings. We found actually that the prevalence of stigma is very high. You can see 3 dimensions here: enacted stigma, so this is about what people feel they're experiencing in terms of discrimination; internalized stigma, so how they reflect sort of that stigma and feeling of shame, for example, reflecting their experiences back to themselves; and also anticipated stigma, which means really kind of fearing that judgment, so which may affect behaviors in terms of seeking help and support. We actually found that about a third regretted having told others about their illness, long COVID specifically, at least sometimes, and about 2/3 were very careful about who they tell about that they have long COVID. So you can read more. There's a conversation piece that we kind of tried to summarize the findings of this study, and it's really important to consider how this is shaping in terms of long COVID stigma. I didn't kind of touch on ethnicity in the dimensions I kind of showed earlier from the ONS data, but we can see that there is from the ONS data, you can see that it looks like people of Black and mixed ethnic background may have lower prevalence for long COVID. Now, whether that is shaped by kind of the reporting nature, whether it's shaped by that stigma, it's difficult to know, and we need more research about it. Certainly in the States, as you can see from this other study, there are different findings in terms of the prevalence of ethnic minorities, and it is, and the authors of that big data analysis in the United States have said, and I agree, that each group appears to experience long COVID differently because of that intersectionality, because of those kind of the combination of characteristics in the wheel of power. So long COVID inverse, I think there's an inverse care law, which is known, since 1970. Julia Tudor Hart came up with it in public health. People who need services the most are kind of receiving the least of the services. And I think that's, happening in long COVID. And it's the inverse care law is shaped by things like lack of information or good information and awareness. The health literacy is really important. How much you know about long COVID, how much you know about what's going on, how much you can self-advocate and your self-efficacy, to kind of push for your care and support. Obviously, we know there's variable definitions, variable clinical care. So there's some sort of a postcode lottery still happening with long COVID. And I touched on the stigma, stereotyping, structural bias, structural inequalities, and trust, which is obviously shaped by all of these things. And these are shaped by socioeconomic factors, employment, poverty, the intersecting social systems of oppression. So I want to ask, do we have an inverse research law, inverse research law as well as inverse care laws? We did a big systematic review on the prevalence of long COVID, obviously studies from across the world, about 130 papers. There were 3 main types of assessments of prevalence, and there's a huge variety, as you would expect, but there's an assessment of healthcare records, self-report, and there are some systematic investigations of pathology. Now, inequalities can affect who takes part in the research for all 3 types of these types of assessment. Many studies didn't really consider ethnicity or deprivation in this. So I'd like you to just very quickly, in the last few minutes, consider this case scenario. So we've got a 40-year-old single mother of 2 school-age children. She is of Black ethnic background. She has pre-existing physical and mental health comorbidity. She has a low-paid frontline job in social care and living in a deprived area. So these are kind of intersectionally combining these high-risk characteristics I showed you earlier. Now, with these characteristics, this person may struggle to access the health service, to access a diagnosis, to access care and support, may not be fully aware of, if there are any long COVID services, whether she can seek any support for her deteriorating health after getting COVID. Now, if she's not reaching the health service, most of research studies do recruit from the health service. So then she would not be represented in the research that takes part in, around long COVID. So community-based recruitment to research is important, I think. It's not easy. So this is community recruitment not from health services, which most long COVID studies do. It's important to co-produce the criteria and the methods. Very important and time-consuming, obviously, and needs a lot of resources to work with locally trusted community organization, builds trust, raise awareness of long COVID, but using community-specific tried and tested methods. Very important to consider research as a two-way process. So there would be, we really need to aspire to have some short-term and specific benefits to participants, not only you're just participating in research for the benefit of the population, which is great, but things around payment for their time, skill development through the research, maybe increase in their knowledge, maybe offer them things like referral to services, etc., within the research study. I'm not going to touch on the results of this, but Ami referred to the health inequalities work we're doing in Stimulate ICP. It is part of that health inequalities work is a community-based case finding study where we're reaching out in 3 sites in London and Derbyshire. And we are writing up the results now and kind of towards completing the analysis around this. But really, this is quite time-consuming to try and recruit from the community, establish some recruitment criteria, and I'm happy to talk a bit more about this. The findings, in addition to the common themes we've heard in this session and elsewhere in terms of the dismissal, and the difficulties in the services, there is actually quite a bit of lack of awareness for people who are not reaching the services. There's a lot of self-doubt on whether they should be reaching out. So there's not that confidence of reaching out to services about their and pushing for their care. And there's a huge worry around employment as well. When I say co-produced research, we need to diversify that as well, because the traditional methods like boards and committees around kind of patient and public involvement may not work for some of these specific groups in the population who are seldom heard. So we may need to have opportunistic engagement, having specific questions, going to community events, whether online or in person. And also mindful of the language. When I say language, I mean the kind of the terms we use, but actually the actual language in terms of, English or whether we need translation. Participant information sheets and research as a barrier, we found out that to be a big thing in, different studies, not only long COVID. So you might want to consider having videos, how to facilitate that sort of barrier of reading all that dense participant information. So the title of today and tomorrow is what needs to happen next. I think in order to narrow population health inequalities, we need research that is representative of those most in need. And when we talk about representation in research, we really need to consider all of these elements. So going back to that case study I gave you of, the woman with long COVID, we need to look at, whether, she's eligible. Well, if we're recruiting from, health services with a definite diagnosis of long COVID, she might not meet the criteria to be eligible. So we need to consider other ways of recruitment. Straightforward study information, the recruitment methods in terms of where we recruit from the community, things about availability for research and being flexible about this, facilitating follow-up, reward. I mentioned about, just to sum up, that the reward bit about what is it in it for the participant, and the trust is really key. And we need community-grounded co-production, so people in the community co-producing the research with us as well. Finish, Nikki. Thank you. Okay.
Perfect timing there, Nisreen. Thank you very much. And I love that wheel of power and privilege. It really hammers home the multiple factors and layers to that. I think that's brilliant. Love it. So again, if you wouldn't mind hanging around, I think there's lots of questions coming through.
Thank you.
So next, we'll move to Ammarah Ahmad, who's providing that crucial patient voice. Ammarah specialises in working within the field of domestic violence, advocating, training, personal development, and volunteer management, in particular, working on the inequalities that many face. During the pandemic, she started working frontline in the NHS, managing frontline volunteers at a hospital. She had COVID in January 2021 and started to experience symptoms a few months later. Ammarah totally crashed by September that year and was off sick for the remainder of her time in this role. She's now had COVID 3 times. Ammarah has been actively involved in long COVID research, which is brilliant. So over to you, Ammarah.
Hi, Nikki. Thank you for the introduction. My name's Ammarah. Can you hear me? Just want to check.
Yes, we can hear
you. So my journey actually into health research started because I actually had long COVID. And it was because of my own experience in terms of the lack of support from medical professionals around me, and also the gaslighting that I experienced, which led me to kind of go onto social media, go onto Facebook and Twitter and start researching to see what was actually out there in the long COVID community in terms of research or support, etc. And I did come across a few different research studies to be involved in. So one of the research I got involved in was the High Coast study. So the High Coast study was looking at the experience of long COVID sufferers from the Arab, South Asian and Black community. So I am on the patient advisory panel for that study. And I also, for the first time, actually went on to a clinical study. It was private funded, but it gave me more. It actually had, how to put it? So it actually had more tests and more benefits that I actually got from it in terms of, because I didn't actually get that from the actual NHS itself. So in terms of what I found is that being on the patient advisory panel for the High Coast study and just being involved in research itself, there's so many barriers that I faced myself and I've seen other people face. Some of them Nisreen has actually touched in her presentation. But first of all, it is that not a lot of people, even till now, know that they've got long COVID. And because word spreads, a lot of people don't actually want to go to their GP because they've known how other people have been treated and how there is a postcode lottery system in terms of the long COVID clinics. So there is a distrust in terms of the services. So they don't actually want to go to their GP, or they don't actually have a formal diagnosis of long COVID. So when it comes to research, it can be quite hard to actually get onto some trials and stuff if you don't actually have that on your medical records. Or I know that some long COVID clinics do have research you can be involved in. So again, that's another barrier if you're not actually gone through the system. So if you don't have a diagnosis, that doesn't actually work in your favor. And because of the lack of trust, that's another issue a lot of people are facing. And when it comes to research, there is this notion, in particular in some communities, that why should I be the guinea pig? There's a lack of understanding, there's a lot of stigma, there's a lot of fear, and there's a lot of unknown, like what's going to happen with my data, what's going to happen in terms of ethical or religious reasons if some people have them, in terms of a clinical trial, what's going to be done with the information if I'm filling out all these forms. So that's another whole big area that actually limits people coming forward. And also because they don't actually know where to look. I was quite fortunate enough to have that proactive approach and go online. And I think my own working background helped me in that. But people generally don't know where to go and where to look in terms of health research. And I know in terms of the community groups I worked with in the past and just talking to people in general, not everyone knows not everyone uses social media. There's language barriers. If you're looking at demographics, if you want to reach the older community, they're not going to be sitting on Facebook groups from a South Asian background wanting to go on to research. So that's where people who are advertising, for example, the High Cove study. So one of the good things I saw in the High Cove study, and I've been on it since the beginning, was when I first found out about the High Cove study, a lot of my symptoms were really badly flared up, especially the brain fog and cognition. So trying to read through a lot of documents and articulating them, understanding them, processing them, but also being new to research and looking at what is my involvement was quite hard to articulate. But the actual team themselves actually took the time. So they answered my questions through email, but also there was a couple of phone calls that we had. And through that, they reassured me, and I knew that because they actually understood my long COVID symptoms and hand in hand answered my question about the research, that was one of my main reasons to go onto it. And even during the study itself, they were so accommodating. There were many times where there was flexibility in terms of the meetings. Even within the meetings, there was, I know myself, there were times where I had issues talking. So they were so sensitive to every different type of symptoms, whether it was memory loss that you were having for a session, cognition issues, not being able to find the links to certain documents they might have sent to read. But also they gave you different options. So for example, I remember when I was involved in reviewing the website for the High Cove study, they gave the option to give the feedback in a written format, or you could arrange a phone call. And it was really good because we were, as a long COVID patient myself, we were able to get the feedback from the study, and we were really heard in terms of our feedback to be given. And that actually changed the quality of the study itself, because I've actually been on studies where I firsthand seen bad practice, where people want you to complete these lengthy questionnaires and they know they have a glitchy app. So you've got an app, you're completing the questionnaire. By the time you've completed it, your fatigue, cognition, all those things have kicked in, but it's nowhere to be found on the app. So you're having to email the person, and you're having to do that several times and not being heard as a patient. So having glitchy apps, and then also having to go back and forth if there's incentives involved, like vouchers, etc., and trying to put them on an app that that's not working, and not listening to someone, it's very bad practice in terms of getting patients involved. Like for the High Cove study, I know that they translated some of the materials into Arabic. There was a better recruitment structures. They actually contacted organizations to help reduce the barriers for people to be involved in the research. So it just shows having firsthand advice from patients themselves on your study, how much of a difference that actually makes. And another thing that I found was that travel is an issue as well. So there's some studies out there that you can be limited due to your geographics. Now, I know that the private funded clinical study that I was on, they actually arranged all the travel, they paid for it, etc. But I remember there was one just on the other, which was in Oxford, but I remember I wanted to go on to a study that was on the other side of London. But because of my accessibility issue, mobility issues, and traveling on public transport, they couldn't actually arrange and pay for a cab. So that limited me to get onto that actual research. So there's a lot of barriers that people are actually facing, but the research itself is important when it comes to long COVID and people's voices being heard. But I do feel that there's more that needs to be done in terms of the clinical studies. And just the last point that I want to touch on is also two things. On the High Cove study, one of the findings actually was that some participants wanted validation before seeking help, and they were referred for a friend. They want to identify with it before actually going on to a study. So that just kind of shows hand in hand what I've just spoken about in terms of trust and building that rapport. And finally, it is that not all people who go on to these studies, it's not just about the incentives in terms of vouchers or money, but when it comes to being paid by NIHR, some of the universities put pressure on the admin teams, put pressure on some of the groups to actually do a big bulk payment at the end of the study. But this, not actually realizing that a lot of people have gone through difficulty to claim benefits, those who are not working, and there's certain criteria where there's a certain limit, whether it's on a weekly basis, monthly basis, etc., that can actually affect your benefits. Now, someone who's going through multiple long COVID symptoms, they don't have it in them to be contacting DWP and be messing around with these type of issues, because they've struggled already to get a benefit. They struggled to find research. So this is just another point that we just need to basically be mindful of. And I am hoping that more people are actually involved in research, and that some of these barriers are spoken about more openly, so that these stigmas are actually reduced. Because I know myself, after taking a proactive approach, how important it was and how it actually helped me, because I actually got more from the research than I actually did from the actual long COVID clinic that was local to me, and from the medical professionals that I have seen, and the lack of care and services through my own experience. Thank you.
Thank you very much, Ammarah. That was fascinating, and I'm sure hit a lot of chords with the audience. Could I ask all the three speakers to pop their video on, and we'll try and deal with a lot of the questions. Thank you. Great. Let's start off, first of all, with where we've been, I think, around the power issues and the ethnicity issues. I mean, I'm very interested in the idea of stigma around this. And to what extent do you think that patients aren't presenting because they fear they'll be stigmatized at work or not well received because they think they might have long COVID? I mean, I saw a patient recently in practice who was a computer programmer who was afraid to be diagnosed with that because they thought it would really affect his work. He was working in cybersecurity. That's obviously one end of the scale, but perhaps at the other, maybe Nisreen, you'd like to expand on that.
I do think it's affecting people reaching out significantly, maybe even more than before. And we are definitely, from the preliminary finding from our case finding, so this is where we're not recruiting from health service, we're recruiting people who've not accessed health services. They might have gone to their GP once mentioning health deterioration, but definitely not got a diagnosis. There is a lot of fear of judgment around, saying, oh, I think that I might have long COVID, So I think we need to do definitely more in terms of validating people's experiences. So, because with people with basically the whole thing is that you have these thoughts about self-doubt, stigma, etc. And I think the least we can do is validate for people, this is not only you, this is a common experience for many people, and that shouldn't prevent you from kind of reaching out. And I think with the next stage of what we're doing, is we really would like to kind of bring these concepts into the consultation. So we can't fix the interactions around consultation, but we can validate people's experiences. So this kind of this is a stigma, this is a problem, so it's present in that consultation. So for both parties, I guess, for the professional and for the patients to be aware of it. I think you asked another question, didn't you? And I forgot what it is now.
Yeah, me too. There's a question on the thing here. maybe both of you and Ammarah, why do you think it is that certain ethnic groups are underrepresented in patients with long COVID?
But for this particular study, we had 3 ethnic groups that we wanted to recruit from, and particularly the Arabic ethnic group. We really struggled to recruit from people of Arabic background, and I think, and it's very hard to know, but I do think, and it'll be interesting to hear your reflections about it, is to do with, and we did translate, my first language is Arabic, so I did videos and things around, kind of the language issue, tried to disseminate on social media, but I think it's about really, it might be to do with the label itself and what that means for people. I don't know, Ammarah, if you have any reflections on that.
I think it can be for a number of different reasons across different community groups. I think, again, it's sometimes we assume everyone's on social media, but I think sometimes we need to take a more proactive approach and contact organizations that are working with, like, for example, the Arab community. Like, different boroughs have different groups and community groups set up. So it's reaching out to them and educating them, firstly, about what research actually is and how it benefits your health, and trying to break down those stigmas, those fears people actually have, before actually getting them involved in research. Like, it's a lot of pre-work that I feel needs to be done. Like I said myself, if I hadn't got long COVID, I probably wouldn't have been involved in a research study, but it's changed that for me. So it's that perception that we need to change. But I also feel that we have gone through a pandemic, and there's certain labels that have been left. Like, I know certain professionals have said to me, just go do some exercise and get yourself back to work. So that actually travels. So that travels within communities like everything else does. So I know there's so many people that don't come forward and now don't actually go and even see a GP to talk about their long COVID symptoms. So that's going to be another practical barrier for them to get involved in health research. And then the findings of the high COVID study have clearly showed that people want that trust, they want that validation, they want to be heard, but we have to validate that they have long COVID. So it comes back to that, basically. I hope that's answered the question.
Thank you. Ami, do you have any thoughts on this?
Yeah, I definitely echo both Nisreen and Ammarah, but I'd add that we know across almost all other diseases that whether it's ethnic minorities or other protected characteristics, which are the basis of inequality that exist, and that can be access to services, that can be people less likely to present with their symptoms, and in my own area, if you look at chest pain, women are less likely to present, people with ethnic minority to present. I think that's what I was alluding to, that we should do more of kind of learning from other diseases and thinking outside of our silos, because there are things that are specific to long COVID, and there's problems that were there outside of long COVID, and we need to apply the lessons, some of which are that we haven't done the right things, and let's not make the same mistakes in long COVID.
Yeah. So, I mean, there's a whole bunch of questions around your trial and various things. So,
well, I've got to go. Sorry.
I mean, first of all, the simple ones. I'm sure, like me, you get emails quite regularly from people saying, "Can I join the X, Y, or Z study or trial?" and things. Is it possible for people in the community not going through one of your 6 long COVID clinics to join your trial, first of all?
So we are, thanks, Brendan. So we are adding sites. I mentioned that are drug only, not so won't be doing the scan and the rehab, in order to make it easier to add other sites. We have 5 sites like that we're talking to at the moment, and the first of them should be opening in August. The answer is, the way we're set up, we can't open to anybody unless there is a site that's been open, unfortunately. just logistically, that's very difficult on a personal level as well. Just in the last 2-3 days, I've had a friend from school and a friend from university look me up and contact me, and with neither of them can we open up the study. So we're as researchers, we're patients and people and carers as well.
Yeah, absolutely. When do you expect the first results?
Despite the much lower recruitment than we'd anticipated in the slow recruitment, we still anticipate results. So we would hope to stop recruitment for both the scan arm and the existing drug arms in December and complete follow-up in March. At the moment, our study is funded until the end of March. So we would hope to have interim findings perhaps at the end of this year and final results kind of as soon as we can. We are looking into the possibility of adding other drug arms at the moment as well.
Can I just quickly ask there, Ami, you mentioned slow recruitment. Why do you think that happened?
I think there's several reasons. One is compared to when we got funded and when we actually could start the drug recruitment, there was in total about a year of delay for various reasons. Even after we started, there have been delays with getting amendments approved. I think also, as with many areas of COVID and long COVID, there's information and there's misinformation, and in whether it's online or in clinics, people have sometimes got misconceptions about what it is that we're doing. And finally, I would say that we have particularly in the last 6 months, had less new people going through the clinics, and more people who, obviously the numbers don't add up in that there's people still with long COVID, but they have long-standing long COVID from the first 2-3 waves. And those are people now, as I said, we've got an amendment that I hope to hear later this month so that we can accept those people into our study, which we couldn't initially because of the design where we were testing a pathway in people with newly diagnosed long COVID.
Thank you. To kind of wrap up, I mean, I think also from our experience in the locomotion study, I managed myself, it's a very similar sort of thing. There's a bit of a change in the landscape from being less people with new long COVID, probably for the impact of vaccination and things, and a larger group of people who have long COVID who've had it for a long time. So it's evolving from a new condition to what looks like a long-term condition that's immunological, vascular, neurological in its thing. And I wonder how all of the panelists think that will change what kind of research we need to do in the next 2 or 3 years, and how we might get the funding for that. It's another issue. Let's start with you, Ami, and move.
Yeah, I think initially I was quite despondent that both the attention and the funding resources were less dedicated to long COVID. But as I said in my final slide, I think this is an opportunity. Unfortunately, long COVID has to be recognised as a chronic condition, on a par in its impact and whether that's on individuals or the health system, it should be on a par with other chronic diseases. And so I think whether it's in terms of funding applications, whether it's in terms of planning services, we need to think how we get that parity and how potentially we lean on other disease services. I mean, we've not done terribly well in clinical medicine in the last 20 years at being over super specialized. And I think we might, I'm talking to you, in primary care, who's well aware of this, but I think that we need to do much better at being holistic, and I think long COVID can give us that opportunity.
Yeah. Nisreen, any closing comments on that?
I think just going back to kind of what we're calling long COVID, I think going back to what I showed, the wheel of privilege, people at maybe more towards the center of the wheel might have this high health literacy, self-advocacy, so they're not calling themselves long COVID because they could get more help and support if they have alternative diagnoses. People at the kind of edge of the wheel, or mainly characteristics at the edge, have a lot of stigma, kind of fear of judgment, fear for their employments, and lack of awareness. So I think either way, that's sort of the way it's kind of who is in this long COVID diagnosis or definition. I think we should try and destigmatize it rather than kind of say, oh, okay, whatever works for people, and we can call it other things, and if things work, because actually that happens over and over again in other chronic conditions. And if you don't have, first of all, it's a multi-system disease, so you're always struggling if you divide it, and also if you don't have that sort of causative pathway, there is a lot of struggles, and with as we've seen with other diseases. So I think we should fight for it. We may call it other things, and it is called other things. Post-acute COVID, post-COVID-19 syndrome. It's fine, but I think it's important to maintain that it is, like Ami says, this is a big chronic disease entity.
Just quickly, bear with me because I think I've used all my energy in my session, so my talking has become very limited now. I agree with what everyone said, but I think the big, massive part is, yes, I agree, we need to advocate for long COVID to be an entity of its own, but the biggest work is to actually educate everyone within the NHS system to reduce the gaslighting, for them to actually understand long COVID is real, because we can get all these titles and etc. But if me and other long COVID sufferers are going into A&E or going into specific services and being told by those professionals long COVID doesn't exist, that's not going to help anyone. We're not going to get anywhere.
Yeah, absolutely. Okay. Thank you.
Thank you very much for everyone, all the speakers, all the chairs for the sessions. I apologize once again for the technical difficulties we had at the beginning, especially for the first session. However, hopefully we managed to rectify that and everyone was managed to view the next couple of sessions. Just to remind everyone that we're going to start again at 10 tomorrow, and topics are going to largely focus around long COVID in the economy and the impact it's had, as well as how research makes it into clinical guidelines. And then we're going to have an hour panel discussion answering a lot more of your questions and having a general discussion about where we are now and where we want to go next. So thank you very much, and we will see everyone tomorrow at 10. Thank you.
Thanks, everyone. Thank you, all the speakers. Thank you, Nikki.